Hello friends, today we are going to discuss leptospirosis in ICU. This article was published in IGCCM. So, leptospirosis is the zoonotic disease and is caused by the spirochetes Leptospira interrogans. Contact of mucosa with the urine of infected rodents, wolves, cats, and sheep leads to the infection. So, rodents are the major reservoir. It is endemic in India with the peak coinciding with with late monsoon. Clinical presentation is biphasic. The first phase is anicteric phase, which lasts for 3 to 7 days, in which patient presents with the fever, chills, headache, anorexia, diarrhea, abdominal pain, severe myalgia, conjunctival suffusion, or hemorrhage, of which 90% recovers. In the remaining 10% of patients, the symptom relapse within the 1 to 3 days of the initial improvement and progress to more severe form of disease called as Weil's disease. It is characterized by the deepening of jaundice, acute kidney injury with renal failure, acute respiratory distress syndrome with pulmonary hemorrhage, disseminated intravascular coagulation, and multi-organ dysfunction syndrome. So leptospirosis clinical spectrum in the critical care, it is manifested as multi-organ dysfunction syndrome, ARDS with thrombocytopenia and renal failure. So icteric leptospirosis, serum bilirubin level of 25 to 30 mg per dl are observed. There is moderate transaminitis and minor elevation in alkaline phosphatase. In the hepatic manifestation observed were jaundice in 72% of cases, hepatomegaly in 67%, transaminitis in 81%, and raised bilirubin in 60%. So jaundice occurring in leptospirosis is not consequences of hepatocellular necrosis and liver dysfunction is reversible after treatment. So next manifestation is the acute renal injury. So acute renal injury in the leptospirosis could be pre-renal or renal and seen in 16 to 40% of cases. The pre-renal mechanism include hypovolemia and hypotension secondary to the third space loss caused by leptospirosis induced vasculitis. Bleeding due to thrombocytopenia aggravates hypovolemia. Then tubular injury causing the acute tubular interstitial nephritis can be direct or through toxin-mediated immune mechanism. Rhabdomyolysis secondary to the severe myalgia of leptospirosis contribute to the tubular injury. So, leptospirosis is non-oliguric with the reduced serum potassium level. Decreased sodium absorption due to proximal tubular damage results in increased sodium load in medullary collecting tubule where it is exchanged for potassium, explaining hypokalemia. Now, the next manifestation is acute respiratory distress syndrome. Patient is presenting with the cough, dyspnea, moderate to severe hemoptysis. Radiology may reveal the diffuse intraalveolar hemorrhage. Then the patient had pulmonary hemorrhage and mechanical ventilation is required. So in some cases, dyspnea, chest infiltration are poor prognostic indicators and mortality predictors in severe leptospirosis. Then the patient can manifest as DIC and thrombocytopenia. Thrombocytopenia is increasingly observed in the leptospirosis-induced DIC in intensive care, a feature that was previously hallmark of dengue, malaria, and rickettsia. Bleeding tendency is manifested as subconjunctival hemorrhage, dependent ankle patechi, ecchymosis, and venipuncture around the venipuncture site. A sudden bout of hemoptysis in stable patient of leptospirosis is often marker of fatality, reflecting extensive alveolar hemorrhage with DIC being second contributory factor. Occasionally, massive upper gastrointestinal hemorrhage may occur as pre-terminal event. Then macrophage activation syndrome has been reported as a cause of pancytopenia in leptospirosis. Now, regarding cardiac manifestation, ECG changes of atrial fibrillation, AV conduction block, non-specific ventricular repolarization occur secondary to myocarditis and electrolyte abnormality. So atrial fibrillation occurs in 12%, is the commonest ECG abnormality. It is followed by T-wave inversion, which is occurred into the 10% of cases, type 1 AV block in 8%, and sinus bradycardia in 6%. ECG abnormalities predicted in the development of ARDS, dialysis requiring renal failure, MODS, and morbidity. However, reduced left ventricular ejection fraction on 2D echo was seen only in 5 patients in this study. Then next is neurological manifestation. It is seen in 10 to 15% of patients. And the differential diagnosis in the comatose patient with leptospirosis include uremia, hepatic encephalopathy, meningoencephalitis, intracerebral hemorrhage due to bleeding diathesis, electrolyte abnormalities, secondary bacterial meningitis, and aseptic meningitis being commonest. The other rare presentations include GBS, myelopathy, cerebellar dysfunction. Then Matthews et al. Reported 31 cases of neurological manifestation of leptospirosis. 25 patients had altered sensorium and had acute symptomatic seizure at the time of presentation, and only 3 patients had localizing deficit. Then coma at presentation and raised CSF protein were the two poor prognostic factors. Now the next is pancreatitis. Pancreatitis is being increasingly recognized in the tropical infection like leptospirosis, malaria, dengue presenting to the IC. The mechanism attributed to ischemic injury to the pancreas leading to autodigestion due to proteolytic enzyme activation. In leptospirosis, renal failure may contribute to the elevated serum amylase level. Hence, elevation of serum lipase level is more specific for diagnosing pancreatitis. Now, regarding lab investigation in critical care in lepto. Complete blood count revealed leukocytosis secondary to sepsis, thrombocytopenia, and occasionally pancytopenia secondary to the macrophage activating syndrome. DIC may result in deranged prothrombin time, low fibrinogen, high D-dimer levels, increased level of serum creatinine, blood urea, bilirubin, transaminitis are found. Electrolyte abnormalities include hyponatremia, hypokalemia, and hypomagnesemia. Electrolyte abnormalities may result in ECG changes and arrhythmias. Urine analysis may show proteinuria, granular cast, and occasionally microscopic hematuria, suggestive of glomerulonephritis. Serum creatinine kinase may be elevated due to rhabdomyolysis. CSF studies showed lymphocytic pleocytosis with elevated protein level. Then chest CT scan may reveal ground glass opacities. In study by Mona et al. Showed that patient had signs of pulmonary hemorrhages on chest radiograph. So the diagnosis of leptospirosis is most frequently done by serologies, and antibodies appear from 5 to 7 days of illness. The sensitivity and specificity of IgM ELISA is 89 to 94%, while that of the microscopic agglutination test is 63 to 97%. A single titer of more than 1 is to 800 of microscopic agglutination test is sufficient indicator of present or recent infection. During bacteremia phase, the organism may be isolated from the blood culture and after the first week from the urine. Molecular techniques such as real-time reverse transcription, polymerase chain reaction are useful for rapid, accurate diagnosis of acute leptospirosis and have advantage over serology of earlier positive. Then leptospirosis in ICU risk stratification. Initially in 1982, the World Health Organization guideline advocated the use of Phoenix criteria for diagnosis and severity assessment of the leptospirosis. So Phoenix criteria used the 9 clinical parameters, 3 epidemiological factors, and 4 bacteriological lab findings. Then the lepto score for risk stratification for the leptospirosis. This score consists of 7 parameters. A score of more than 6 indicates need for ICU admission, mechanical ventilation, and inotropes or vasopressor support. The Smith et al. In Australia devised the 3-point score, that is the Spiro score, using systolic blood pressure of less than or equal to 100, respiratory auscultation abnormality, and oliguria as clinical variable, with each component awarded single point. A Spiro score less than 1 had negative predictive value for severe disease of 97%. It can be quickly calculated in the emergency medical services instead of routinely used SOFA score for triage of the patient with leptospirosis in need of intensive care. Spiro score was found to be superior to SOFA score in AMS setting. Now, now regarding leptospirosis, ICU management. Severe illness due to leptospirosis needs intensive care unit management. AKI secondary to hypovolemia needs correction by intravenous saline fluid with potassium supplementation done carefully, avoiding side effects of the fluid overdose. Acute tubular necrosis causing non-oliguric renal failure may necessitate renal replacement therapy. Recent studies have shown that early initiation of the dialysis in the leptospirosis is beneficial and help in mortality reduction. In an ICU study carried out by Andre et al. In Sao Paulo, in 33 patients of leptospirosis with renal failure, a significant reduction in mortality was observed in the group undergoing early and daily dialysis as compared to the group receiving late onset alternate daily dialysis. Patients suspected to have ARDS or alveolar macrophages need mechanical ventilation, lung protective strategies. DIC needs correction of coagulation parameter with fresh frozen plasma and packed red cell transfusion. The recommended antimicrobial agent with benzyl penicillin, that is 1.5 million unit intravenously every 6 hours, and doxycycline, that is 100 mg IV twice daily, and ceftriaxone, that is 1 to 2 gram IV once daily, or cefotoxin, that is 1 gram every 6 hours, given for period of 7 days. Patient with leptospirosis with meningoencephalitis may need the higher dose of benzyl penicillin of 20 LIV at 6-hour duration for 2 to 3 days, 2 to 3 weeks. In study done by Daheller et al. In Brazilian ICU, the early use of ceftriaxone was found to prevent severe leptospirosis. Antibiotic susceptibility testing is not done routinely as resistance is rare. An inflammatory response to the clearance of spirochete is called as Jerix-Hexmer reaction occurs post-treatment. It is characterized by the fever, rigors, and hypotension. Elian et al. Found corticosteroid beneficial in patients of moderate to severe thrombocytopenia due to leptospirosis. They used prednisolone in the dose of 1 mg per kg for a period of 1 week. The Trivedi et al. Found the beneficial effect of using IV high-dose pulse methylprednisolone for 3 days, followed by 1 mg per kg prednisolone for 7 days in patients with ARDS and myocarditis. So, so regarding difficult to manage patient, the highest mortality in the leptospirosis in critical care is seen in hemorrhagic ARDS. The renal failure of leptospirosis is usually non-oliveric. And hemodialysis is beneficial in patients with the uremia and fluid overload when indicated. Rarely, septic ATN may cause prolonged oliguric renal failure, needing maintenance hemodialysis till the kidney recovers. Such a patient, especially those on invasive ventilation, are highly likely to develop secondary bacterial sepsis. Appropriate time blood culture, judicious use of higher antibiotic combined with excellent day-to-day nursing care will salvage such a patient with who otherwise have poor outcome. Persistent hypotension, despite optimal fluid resuscitation, point to the presence of myocarditis and septic shock. In combination with the hemorrhagic ARDS and oliguric renal failure, it confers the worst prognosis. Vasopressor like noradrenaline, dobutamine, and vasopressin and fluids need careful titration, especially in patients with high positive end expiratory pressure requiring ARDS and or those on hemodialysis to avoid hypotension. In patients with leptospirosis with persistent ongoing vasculitis, intravenous immunoglobulin has been suggested as the last option to tackle this immune-mediated phenomenon. Regarding leptospirosis in pregnancy, this is associated with higher fetal and maternal mortality. The differentials of hepatorenal presentation in pregnancy include acute fatty liver of pregnancy, HELLP syndrome, viral hepatitis, apart from classical infections like malaria and dengue. So, leptospirosis outcome in pregnancy, outcome in ICU, published data are available from both developed and developing countries. In the encouraging study by Smith et al. To reduce the mortality, it was found that ICU support and corticosteroid therapy is associated with the reduction in the case fatality rate, and all patients in this study were treated with antibiotic therapy initiated within first 6 hours. 48 patients had EKI, out of which 18 require RRT and 34 patients needs vasopressor support. So only 20 patients received corticosteroid. Two patients who succumbed were elderly with multiple comorbidities. So Delmas et al. In the study of 134 patients found that severe leptospirosis has lower mortality with prompt resuscitation despite high initial spiro score. And Costa et al. Found that late presentation to healthcare facilities in severe cases contribute to high mortality rate of 5 to 15%. In multi-center study conducted in 79 ICU of the France, mortality at 9% was associated with elderly patient, leukocytosis, invasive ventilation, need for dialysis, ethanol addiction, hepatic encephalopathy. The leptospirosis causing hepatorenal, neurological, and respiratory complication with pulmonary hemorrhage had highest mortality predictability. And in Vartanga et al. Study done in Sri Lanka, high mortality of 44.4% was associated with low pH with very high CRP level, hyperkalemia, metabolic acidosis, and multi-organ system failure. Chronic alcohol abuse in Indian setting will be the hidden contributory factor towards the mortality in leptospirosis. Thank you, guys.